The goals for this patient's therapy are to treat symptoms, to treat the disease burden, and then try to keep the patient alive as long as possible. Many patients with EGFR mutations can live for many, many years because first they get the first agent and hopefully they don't become resistant for quite some time, and then they get the next agent. Now, of course, we have newer agents such as osimertinib in this area that target the most common form of resistance, is called T790M. So this is a very hopeful situation. Multimodality therapy is critical because if we find the patient has disease in the brain, for example, the CNS, one might want to treat. In some cases, we might just use the EGFR agent first alone. But if someone has significant brain lesions, we might want to use gamma knife or radiosurgery, as some call it, whole brain radiation. So that's important to know. We also want to know if there are any lesions anyplace else in the body that are of high risk to the patient that might need radiation therapy early on. Certainly surgery as needed, but it is important to do a multimodality evaluation to look at the patient from stem to stern and understand what the burden of disease is and what local therapy might be needed. All of cancer therapy is a balance between local and systemic therapy, and one needs both. I don't think you're going to cure someone with systemic disease just with local therapy, but certainly you can treat some symptoms which will allow them to remain on the systemic therapy for longer periods of time and hence have more chance of benefit. The performance status is the most critical feature I look at in this or any patient. And a performance status of 2, I haven't met the patient, I'm told it's 2. It could be my 2 or my colleague's 2. Some people's 2s, are better 2s than others, and you really do need to see the patient, and I have enough experience now after many years that I can tell who can get chemotherapy and who can't. When I hear 2, immediately my mind goes off the light bulb. We probably can't, use chemotherapy. Or if we did use chemotherapy, maybe we use a single agent. But then again, it would be a palliative therapy at best with chemotherapy. But then when I hear it's performance status 2, and it's a patient who has EGFR mutation, I get excited for the patient, and to try to communicate to the patient that there is a therapy that can hopefully shrink some tumor. You might notice a benefit, within a couple of days, almost immediate, and why not try it? And sometimes you have to convince the patient to do it because these patients can be quite sick and maybe they're wheelchair bound. A performance status 2 patient usually comes to your office in a wheelchair. But this would be the patient where I would say, look, your performance status is diminished, you've got widespread disease, let's give this drug a try for a couple of weeks and see what happens. And the good thing is, the testing is usually quick. Most centers less than 2 weeks, usually sooner. The drugs are usually available. Most places are quite familiar with the major side effects of an EGFR inhibitor, rash and loose stool, and we move forward. So this patient, it might be a perfect therapy. They're probably needing some pain medication for the bone mets. The oral EGFR agent will probably act to help with any constipation that might provide. And then we hope to see a response, and we follow these patients. Bone mets are a difficult disease to treat, but hopefully that and the lung lesion and any other disease in the body will be treated. And the good news here is this patient does not have brain disease yet. He might at some point get that. We have to keep an eye out for that. But right now, full speed ahead to start the EGFR therapy, and then of course manage the patient carefully because we do know that resistance will develop. It's not if, but it's just when. When you think of the modalities of care for lung cancer, supportive care has to be right at the top of the list, especially since in most cases we're still treating palliatively, although our goals are more ambitious than they were. Here we have an EGFR inhibitor that we're using, and hopefully this patient will have a nice response and feel better. But early palliative care and supportive care have been shown to improve outcome in patients with lung cancer and need to be used as early as possible. We are treating the entire patient, so if this patient were in my clinic, I would probably begin palliative care measures with oral pain medicines, but I would also probably refer them to the palliative care service to help as well. A patient like this, who I'm starting an EGFR inhibitor on, I'd probably want to see at least monthly, but normally I work very closely with a nurse practitioner, so I would have either her or me see the patient in 2 weeks. I like to do this for a number of reasons. There's interstitial lung disease that develops with these agents. You hardly ever see it, but I've seen it a few times, and it happens 1 in 500 or maybe a little bit less. But I just like to bring someone in and see how they're doing. Also gives us a chance, as long as they don't live too far away, to check their skin, to check their, how they're doing with diarrhea and other, in this case, we can, monitor the pain. So I usually like to see the patients, early on, and then usually on a monthly basis, and I would probably do scans every 8 weeks.